Hello, I'm Merrick Olson with KSMQ Public Television.
And I'm Nicole Fenoy-Hara. Welcome to our special program on Q Insight, looking into the future of rural healthcare in our region and beyond.
We've assembled an expert panel to discuss an important topic that's hit the local headlines recently. Back in June, Mayo Clinic Health System announced that it was ending inpatient hospital and birthing services in Albert Lea. Future patients would travel 20 miles for care to Mayo Clinic Health System's facility in Austin. Now, that announcement has caused upset and concern among many residents in Albert Lea.
And Albert Lea is by no means alone. Take obstetric services, for example. A recent study found that in just the last 10 years, 179 rural counties in the United States lost their access to in-county hospital obstetric services, forcing patients to drive an average of 29 miles to the nearest birthing center.
So what's happening to health care access in rural Minnesota and beyond? Let's learn from our panel. We welcome Ira Moscovice, Director of the Rural Health Research Center at the University of Minnesota. Also, Carrie Bunkers is here. Dr. Bunkers is Medical Director of the Office of Population Health Management at Mayo Clinic and a family physician with Mayo Clinic Health System in Owatonna. Rounding out our panel is Laura Beasley, Associate Dean of Allied Health and Director of Nursing at Riverland Community College. Thank you all for joining us very much. Dr. Mosk, I start with you. What is it about rural health care? Is this happening, this kind of event that we're seeing in Albert Lea and Austin? Is it just here, or is it happening all over the country?
No, it's happening all over the country, and what we're simply seeing is as we go through healthcare reform, no matter what happens in the future with respect to which specific reform bill is going to get passed, what we're seeing is that it's harder and harder for both recruitment of rural health professionals and also in terms of gaining access to the system for individuals living in rural communities. And that access issue is geographic, it's also financial, so it has several components. But what we're seeing here in terms of the situation with rural communities in Minnesota, it's really playing out all across the country.
And you're studying this, you've had a few papers out on this. What has changed? Is it we're waiting for healthcare to the reform bill to go, or has this been building for a long time?
Well, it's been building for a long time, and what we're really seeing in the healthcare system is consolidation of the system. And by that we mean health providers, physicians, nurses, clinics are consolidating, they're integrating, they're working together now, and often under one umbrella, whether it's the Mayo Health System or Intermountain Healthcare or Geisinger or other Kaiser Health, all these large health systems. And when you have that kind of consolidation, the issue that is faced is how can we provide services efficiently? What's the best way to do that? And there are trade-offs in terms of the cost side, the access side, and the quality side, which we'll probably talk a little bit about later. So that trade-off about how can you get the right health professionals in communities, how can you provide services so that they are financially viable both at the institution level but also in terms of people accessing them. These are hard questions, and they're playing out all across the country, and the responses and the solutions differ across the country. Rural Minnesota is not like rural Delta down in Southeast, it's not like rural Maine, and so you really need context or environment. You want solutions that fit the environmental context that's being considered.
Right. And how would you characterize, I guess, that cultural geography of this region in terms of the rural healthcare needs? What's unique about
what
it?
we've seen in the state of Minnesota is we have several large healthcare systems. The Mayo Clinic, we have the Fairview Health System and other health systems in the Twin Cities. We have Essentia Healthcare up in the northern portion of the state. And the challenge is really for rural providers to say, I'm going to stay independent. Will I continue as we have been? And can I afford to do that? Do I have the technology, the information systems, and the staff that will allow me to remain independent? Or do I need to join other healthcare systems so that I can get access to those kinds of, as I say, technology, resources, staff, et cetera? And that's a very difficult question for local communities to come up with an answer for.
And that's a systemic issue. Dr. Bunkers, how does that relate to you, those challenges in your day-to-day world in Owatonna and the region when you're caring for patients and there's rural, metro, different uses of healthcare? Has that impacted your practice at all?
Certainly. We've seen a lot of changes in technology, over the last, especially the last 10 years, as electronic medical records have really become mainstream in an effort to allow us to have more things electronified and allow us to communicate with each other. So if you're hospitalized in Dallas, physicians there are able to access your records from Minnesota, vice versa.
And educate me, we've got time here. Well, everything you folks are saying is educate me, but you have kind of chronic healthcare needs or acute, right? And those differences are, acute is you break your leg, am I getting that right? Mm-hmm. And chronic is more diabetes.
Right.
And that go on and on. Do you see a change in the kinds of cases that the health system is seeing, that you're seeing between those two types of healthcare?
So as America ages, and the baby boomers are now, hitting Medicare age, we're starting to see people living longer, and living longer with more chronic conditions. And what that does is it shifts. We used to be a Medicare or a medical society where people when sick, then they come into the clinic and we treat one thing at a time. But now, as you live longer with multiple chronic conditions, we need to do a better job of managing those conditions and not just treating acute needs and then saying goodbye and I'll see you next time. So how do we do that more effectively when you're not in the clinic? And that's what population health is all about, trying to deliver better care to the population to achieve what we call the triple aim. And that is doing so, keeping our population healthy, but doing it at a lower overall cost and in a way that brings a better experience of that care for you.
Laura Beasley, I wonder, your incoming students, you teach about 100 in your department,
Mm-hmm.
want to be nurses. Mm-hmm. Do they come in saying, I really want to work in the country, I want to work in a rural environment? Or there's probably no model average student, but is there a lot of interest in providing health care in the rural areas? Because we hear that's the tough challenge, is finding people who want to work there.
I think on average when students come to our program, they think hospital, that they want to work in a hospital. And I think it's becoming more so now where students are seeing that they can work in different settings other than the hospital. So we try to give them experience not just in the hospital, but also in the public setting. Maybe school nursing, long-term care, home health. There's such a need right now in Minnesota for home health care nurses. And so I don't think that's always been a popular profession in the past, but I think it's becoming more popular now, and it's not just so hospital-based. I think when I started nursing school, I thought, I'm going to work in a hospital. I was never exposed to the different areas in healthcare, like long-term care. We had very little experience there. It was all hospital-based. And so now the curriculum has changed here, where the first semester, they're out in the community. They're working with school nurses. They're working with public health professionals. So we're trying to give them that exposure, because there's more than just working in the hospital, and there's a need. So we want to try and meet that need.
I mean, that's a really great point. I think we often think that hospital and physical healthcare institutions are going to solve all the problems, or that's what we need more of. Can you talk a little bit about how systems can work together in terms of collaboration with public health, human service agencies, nonprofits, things like that, in terms of providing that care to places that can't access it geographically?
I'll start off.
Yeah,
Oh,
sure.
okay, go ahead.
No, go ahead.
I'll be glad. And so I think you've asked a challenging question. How can these institutions that have primarily been inpatient focused for a long while, how can they start building the bridges? And they've started, but when we talk about population health, you can't do that as an institution yourself. You really do need, whether it's connections with local public health agencies, with the school system, with the justice system, and those are challenging connections to make if you haven't had experience with that. But that's sort of where we're heading. I think it's important to recognize across the country, on average, the majority of revenues for hospitals now don't come from the inpatient side. That's both in rural hospitals and in urban hospitals. It comes from the outpatient side. And so everything is moving outside the walls of the hospital per se, or in terms of whether it's satellite clinics or people are doing surgeries now. A lot of surgery is outpatient, not inpatient. And so the emphasis I believe we have to put is on those kinds of avenues and building those kinds of collaborations. It's the only way we're going to get true population health management. And I would just, final thing, say, but the reimbursement system doesn't focus that way right now. And so we pay for doing things, not for taking care of people. And we're moving over slowly to that. But in terms of where things are heading for the future, the reimbursement system is going to need a change to really value those kinds of relationships.
And you're nodding your head, and I don't want you to be the spokesperson for hospitals. We asked Olmsted Medical and Mercy, they couldn't make it here today, but you were nodding your head in agreement with that kind of struggle with regard to funding and reimbursements.
Absolutely. I agree that, if we look at the last 20 years, things that used to be taken care of in the ICU have moved, to the floor in the hospital, and what was taken care of in the hospital has moved to the outpatient. And all of it's shifting towards more care being delivered at the lowest cost setting, because healthcare is expensive, and we found that we don't have to deliver it all in the hospital. But we can't do it alone. We can't, we need those partnerships with public health and, all the agencies in the local communities to help partner with health and wellness and delivering the services that keep our communities healthy.
And I wonder about, you said population health, and I didn't know about that. Is that a genre or a mode of looking at things? As my understanding in talking with you earlier, hospital is definitely one facet of health, but if you want to talk longevity of life, there are other factors that regions, communities have to or ought to be looking at for an overall health portfolio that helps people live longer, that might not just be the hospital you visit every 5 years or so.
It's really
fill me in
partnering.
on how I got that wrong or part right or what.
I think it's involving the entire community in caring for a population and shifting the focus from one patient at a time, visiting one doctor at a time, toward a care team and a community caring for the entire population in settings that make the most sense for that particular situation. So, for example, if you have a cold, or let's say you have pink eye, I think was the example I used with you, you don't necessarily need to come in to see a physician. That's a very expensive resource. There's potential we could treat that over the phone or over, on a message, email type of a situation, and that saves resources in the clinic for people that are sicker, but it also saves you time and saves everyone cost. So that's what population health is about, trying to redesign the way we deliver care to achieve that triple aim.
And who's responsible for facilitating that process, I guess? I mean, you said that perhaps it wasn't just institutions, it's, sort of everybody outside of that in the community, but sort of who, pulls that trigger in terms of getting those people together, getting those institutions, non-institutions together to do that?
From my perspective, we can't identify one person. It really depends on the communities you're in. You would like these solutions to come from the bottom up. Mm-hmm. You really don't want them to come from the top down. You want the community to understand what do they really need, what's important, and then work with the health system, the school system, the justice system, and so forth. But it depends on the dynamics. There are some communities that have terrific leaders, and they will put health and the issues we're talking about at the top of their agenda, but there are other communities where it does have to come from the health arena, and hopefully jointly in those cases from both health systems, but also from local public health and others. And so it really depends, but it can't just be one person.
From the college standpoint, what are you looking at for the future workforce needs when we're talking about communities being involved? Would that shift what people need to learn when they're in college to become healthcare facilitators or in the allied health fields?
there's going to be a lot of need for, nurses in the future, but also I think there's going to be a need for other healthcare professionals like, extended nurse aides that might be trained to specifically take care of people with certain diagnoses. So they have to visit the physician less. I think that there's going to be a need for more nurse practitioners, physician's assistants, because there is such a shortage with physicians, not in this area, but in all parts of the country. There's a huge shortage.
Well, man, this area,
yeah.
maybe too.
Yeah.
You're talking about Rochester, if you go
Yeah.
into Rochester city limits, but
It's all over. And not only that, but health coaches within the community to help coach people with
now
health.
what's that? I don't know what that is.
They're just people that would work with certain patients, and correct me if I'm wrong, that they just help coach them through their illness and how to make healthy lifestyle changes, such as maybe nutrition or maybe stop smoking, or to visit the patient regularly to see how they're doing, to check up on them, to see if they have any needs or maybe any educational needs, just to keep driving them forward in the right direction. So there's going to be a need for a lot of different, I think, more creative roles in healthcare that we currently might not have. So, but certainly nurses are always going to be in need. There's definitely going to be a shortage. I think there is already right now. But with the baby boomers retiring in the nursing arena, there's going to be more of a need in the future. So.
Oh my gosh, there
Yeah.
was an article just the other day in the Post Bulletin about the senior citizens and senior care and how you're going to need folks to care for those people. It's a
Yeah.
real problem. Do you see that in your practice?
Absolutely.
Yeah.
I think it's important to understand, though, it's not more physicians we necessarily
Yes.
need, and that when most of the population thinks, well, if we have a shortage, we need more health professionals, we need more physicians. We're really talking about physicians, primary care particularly, nurses, nurse extenders, community health workers, a variety of different kinds of health professionals, and that's what will make it more efficient. And there was, down in the Delta, they have a tremendous shortage of pediatricians, for instance, but a local physician who had been there a long while, so we don't need more pediatricians. I need to have a person like a community health worker who will go visit every household at least once a year. And so if a child has asthma and you go out to the house and you see mold all over the walls, another pediatrician's not going to solve that problem. And so there are a lot of social determinants of health that are really linked to the population health. That was issues that were mentioned earlier, and those are the kinds of issues I think we need to address, and it'll be through a wide range of health professionals.
Are we getting back to the old, my mom was in the Visiting Nurses Association, the old VNA, and I remember as a kid she drove out to farms, and that was her role, to go to every place in the school district, I think, bringing that kind of thing back, that model.
I think there are certainly communities where I think that's going to work really well.
Nationally, a community health worker who's not a nurse. I mean, so we know that they don't even have to be nurses. Nurses have definitely a role to play as well, but community health workers are other individuals that can go into the home and be the eyes of the healthcare team and bring that information back.
Is that something you go to school to be a community health worker? Pardon my, is that like a program that you go to school for? That's, you end up being able to do that, or?
So there are special programs. I think one of the earliest models were up in Alaska, where you have a real shortage of health professionals. And the Public Health Service up there decided that we're going to have a community health worker, a local person in each community, because you can't always get health professionals in during the winter, et cetera. And they had a special training program, not a long one, but a special training program, and they had guidelines, et cetera, to follow. And I think other communities have done that. But I think down the road, if we're going to really solve this problem, we need to think about what curriculum we want health professions to have. How are we going to train medical students? How are we going to train nursing students? And how are we going to train these new kinds of allied health professionals to be the eyes of the system? It's not something you just pick up. You do need to have an interaction with the others in the system. But I think, yeah, I think that's where we're heading.
Tangentially related to that, at the top of the show, we talked a little bit about obstetrics and the average 29 miles that some women are going to need to travel in some of these rural areas. I'm particularly interested in obstetrics currently, and I wonder, are we going to see, a revival of midwifery and doula and birth attendant services, or are we going to, on the flip side of that, have a real public health concern in terms of people not being able to access, prenatal care, delivery, and labor services?
A program that was started at the Mayo Clinic was called OB Nest, and for low-risk women, we know that a lot of the services that you come in for on a monthly visit can be obtained at home. If you had a home fetal monitor, a Doppler, and a blood pressure cuff, which is typically what you come in for, make sure things are going well, those services can be delivered at home with coordination and communication with your healthcare team. So I think we're going to continue to see more and more of that.
And the challenge is I have a colleague, Katie Casamano, who's done a lot of this research that's gotten a lot of press. And once again, it's not just in Minnesota, and you look up in Grand Marais, it's one example in Minnesota where if you live anywhere near Grand Marais, you need to go down to Duluth if you want to have your baby inpatient. And that's more than 29 miles. And so it's a long distance, and the hospital up there closed. And so there are no longer OB services per se. And the question becomes, there are trade-offs, and if you're going to live in an environment like that, it is riskier. And certainly midwifery is a potential answer, but having a home delivery has extra risks, and if you're a low-risk delivery, it's one thing. And so the key thing is, for sure, if you're determined not to be low risk, then you need to figure out, how do I get into an environment that can really take care of me? But as you might imagine, for a lot of people, it's very hard for a lot of women to say, well, a month earlier, I'm going to go down and live in Duluth before I have my baby. That's just, obviously, from a employment perspective, from a personal perspective, family, not a lot of people can do that. And so there are risks involved, and if it's in the winter, you don't know what the weather's going to be. So it's a real challenge, and to provide those services locally certainly is a goal if you can, but you can't always do that. So,
do you get, do some of your nursing students learn about midwifery or those kinds of services as part of their curriculum?
Yeah, they do, and they do have experiences on the OB unit. So they do get a little bit of, practice with that. So, and I think another thing maybe to mention is maybe the emergence of telehealth, is coming, where physicians, they don't have to be right by the patient. They can, so that is something that I don't think a lot of our students get, access to, or they don't get to see it very often. But I think that's something that might be emerging.
So if you're a nurse, how does that work? Is there tele-nurses today too, or do you talk to a doctor who's on the phone with you, but you're near them, or how does that work?
Well, there's a long-term care facility here in Austin that now the physician isn't there anymore. He actually gets rolled around on a cart, and he gets to be in the patient room, and there's a nurse there, collaborating with the patient and the physician. So that is something that is here now, and it's kind of exciting.
Is that an experimental thing, or is it in practice? Like there's a kiosk system also that's being tried?
I think it's been around for a while, but I haven't actually used it, but I hear about it a lot.
I mean, these technologies are really exciting, but are there any barriers in terms of financially for people to access those? We're talking about, again, rural health. There's definitely rural poverty and people not being able to access certain types of, certain levels of care after a certain point. How does that impact accessibility to new technology?
So the focus really isn't at the patient level for that. It's for the provider level. And so we've had telehealth.
So what do you mean by that? Break that down a little bit.
So telehealth's been around for a couple decades now, and it's starting to get used more and more. And we know in certain specialties like dermatology, like psychiatry, the technology has improved so much that you really can do these things. But the issue is you need a provider, a health professional on one side offering advice, and you need a health professional on the other side who's receiving the advice. And different states and the federal government over time have sort of changed their policies as to, are they going to reimburse that? Do you reimburse it the same as an office visit? How much do you pay one side, the receiving side, and how much do you pay the sender side? And we've started to see some movement in that arena, but it doesn't change very much what the patient's paying out of pocket. It's more, can you afford to have that technology, and can you basically get paid for, it's taking people's time, but just in a different fashion.
Laura, what are the top healthcare concerns for farmers these days? I mean, the ag landscape has changed so dramatically. Have their healthcare you grew up on a farm, have the healthcare needs changed?
Not much. In fact, they're saying now that agriculture is one of the most dangerous jobs in the world because of the things that they're exposed to. There's several things that are on the list as far as health concerns. I mean, there's electrocution, there's falling from farm equipment, which I've done many a times. There's pesticides, herbicides, chemicals, dust, the risk of being suffocated in a grain bin. There's so many other things, I can't even list them all, but they're still, I don't think it's changed much as far as the top concerns for farmers, and it's pretty much still steady from a couple of decades ago. But it's a very dangerous job. Then you have also livestock, injuries from livestock. There's too many to list, but it is a very dangerous job.
So the need is still there, obviously. It's not going away, even though the number of farmers is reducing, is smaller.
In terms of agricultural workers in rural communities, they're also changing demographically in a lot of areas. I was just in Wilmer a few months ago, and that community, which has historically been a rural agricultural, mostly white community, has had an influx of immigrants from all over the place, and so that's become a real challenge and I guess opportunity also for public health, for hospitals to respond to. How are we thinking about that in the future in terms of diversity in rural communities and those demographic shifts?
So that's a real challenge. I would say Wilmer's been noted to handle it pretty well, and they've had a lot of experience at this point, but it means you may need interpreters. It means you're going to have different cultures to deal with in terms of how they view the healthcare system, and that's more of a challenge for primary care physicians who, if they haven't been used to that, all of a sudden you have people who are speaking different languages and are not used to, following certain kinds of guidelines, and they weren't trained. Many providers to provide those kinds of services, and so at some point you do have to basically have some interpreters in your hospital because those people are going to be patients in those facilities. So it provides real challenges, but you would hope in the context of population health that we start dealing with those issues in terms of health disparities, health equity, et cetera. So I think we're starting, but we got a ways to go. But it does create real challenges, and particularly if you're in a smaller size facility, it's a lot harder to basically be able to afford those kinds of additional personnel as compared to a health science center where you have a lot more patients to spread that cost over.
And as a
Interesting. Go ahead.
as a family physician in Owatonna, how have you encountered that in your practice, in your everyday practice, some of these demographic shifts? How have you dealt with that?
Certainly, and we have interpreter services virtually, which has allowed us to bring that in more efficiently. But I think the other thing is cultural sensitivity training has become more of a focus because it's not something that we were trained in medical school, those of us that went there 30 some years ago. So starting to see that integrated into more med school curriculums, really cultural competency, understanding how different cultures view medical care and how they interpret what you're saying.
Really? So your diagnosis of a patient might be the same, but you communicate the way you interact with that person is very different, can be. Is that what you mean?
Yes, and you need to understand how they view taking medications or the different things that you're saying that we might take for granted. You know, I say take this medicine and I think that they're going to go take it, but if they have different beliefs, what that means and how I communicate that, then they're not going to take it and get better. So you really need to understand the culture.
Great. Very interesting. Just want to let folks know you're watching a special edition of On Cue Insight. Here on KSMQ Public Television, we're focusing on the future of rural healthcare in our region.
Our guests are Ira Moscovice, Director of the Rural Health Research Center at the University of Minnesota, Carrie Bunkers, Medical Director of the Office of Population Health Management at Mayo Clinic, and Laura Beasley, Associate Dean of Allied Health and Director of Nursing at Riverland Community College.
Laura, is there growing interest in the nursing school? I mean, these days, or are people scared away from it because of all the healthcare problem, not knowing about the Affordable Care Act or where my insurance is coming from? Are there still plenty of students these days?
Yeah, there are. They don't think about those things coming into nursing school. They learn about that while they're in, but no, that's not a barrier at all.
And you have about 100 in this incoming class.
Yep,
and
currently.
You were telling me they all have to go through a certain regimen, nurses in Minnesota, and that means they have to do clinicals, is that what it's called?
Yep.
Talk a little bit about that, where they have to go and what they have to
Sure.
experience.
So we're mandated by the Board of Nursing to give our students experiences across the lifespan, and that's from birth to death. So we have to give them exposure in all those areas, so pediatrics, maternal child, surgery, public health, long-term care, home health. So we have to give them experiences on all those areas.
And you have to work, I would presume, with like Dr. Bunker's facility and others so that your students, I mean, how do they access, like the Mayo Clinic, for instance? Do you have so many students that might go in?
Yes.
How does that work?
Yeah, so we're based, we have semesters, and so each semester we focus on something different. And so, like for the practical nursing program, the first semester they focus on long-term care, chronic illnesses, and then in the second semester we partner up with Mayo Clinic to give them experience with acute care and pediatrics and maternal child, and also we give them exposure to the clinical setting. So we have key partners at Mayo Clinic and with our long-term care facilities to help provide students those experiences.
And switching gears a little bit, in terms of these changes in rural healthcare, what impact do you think they'll have on the economic development of some of these rural communities?
Well, usually the hospital is the largest employer in many smaller rural communities. And so our discussion about what's the future role of the hospital has a major impact on the local economy. And when a hospital closes, as we've seen some rural hospitals around the country closing over the last 5 years, it's not just where am I going to get health care in the future for that community, but what about the local economy and what about all those lost jobs, and are they lost jobs, or can we think about that institution and that facility, can it be changed into a different kind of healthcare facility that meets hopefully some of the needs of the local community. And so it's a major economic driver, the healthcare arena, and it multiplies as you have these jobs. Those people then have resources to spend, funds to spend at local shops and et cetera. So it's a major issue.
What are your thoughts around, I guess, legislation or regulation at that level in terms of who gets to open a hospital, close a hospital in the community?
Well, we live in a free market economy in the United States, and so I don't think that we need to regulate that. I think the market has to play that out. But I think local communities have to think about what are their needs and how can they best be met. And it's really hard to change. I understand that. But communities have to balance sort of this notion of what can we afford, what's financially viable, how can we keep health professionals in our community, what services can we offer, where can we get other services, and it's when we talk about obstetrics, that's one of those sensitive areas where it's not the same if I have a broken foot, if I have to go 20 miles, okay, that's one thing, but to have a baby delivered 20 miles away, That's the kind of discussion that's, has happened locally here, but it's happened in many other communities around the country.
Correct me if I'm wrong, but I think your research we were talking shows that if you had an independent hospital that wasn't part of a group in a small town, that would be an area of concern as far as its future.
Well, what we've seen with smaller rural hospitals is that more than half of them are part of systems like the Mayo Health System. And that's because of all the issues we've been talking about, access to the new technology, electronic medical record, being able to recruit health professionals. It's much easier if you're part of the Mayo system or larger systems like Intermountain out west, Geisinger in Pennsylvania. So there are good examples of these kinds of systems around the country. The challenge is it's the trade-off of locus of control versus basically having to change your behavior as an institution and having some financial viability, et cetera. And that's a very hard decision if that institution's been, if you've had a hospital for 50, 60 years since Hilberton started creating these facilities, and now you're saying maybe it's not going to be a full service, that's a real challenge. And different communities are going to make those decisions, hopefully jointly with healthcare systems that help meet their needs. But it's not easy. It's really not easy.
What kind of work do you do in the population health realm? What kind of projects are you working on, Dr. Bunkers, that people could relate to? Like where's your research going? Where's your studying going?
So as we look at affordability, we talk about delivering the right level of service by the right person at the right place in the right time. So we are moving away from one doctor providing all the care to working with the care team. And so we've formed care teams that you may have, when you come in, you might see the pharmacist if really your needs are mostly talking about your medications, or you might see a social worker, or you might see the registered nurse, all who have skills that can help with certain things, or the dietitian, as opposed to the doctor talking about your housing needs or other instances. We know that we talked about the social determinants of health. A lot of the things that impact how sick we get or what our medical needs are not they're where we live and where we work and our access to food and our jobs, and so all of those things need attention paid and are best delivered by a broader team, not just that one physician.
So how do you make that a reality in communities? I don't know. Yeah, I mean, in Albert Lea, they did this thing called Blue Zones a couple years ago, where they made the sidewalks safer and better and tried to get people up and moving around. Do you need a city to help the healthcare facility, or who are you working with on these
Absolutely.
ideas?
So a great example is Mauer Refreshed. Sandy has done an awesome job of creating a coalition of health and wellness groups in the community. And we partner with groups like that to provide education, and wellness really needs to be owned by the community. It's not something that the hospital or the clinic should own. And so it's partnerships with public health and the schools. So getting an asthma action plan out to the school nurse so they understand what the plan is for that child if they have problems with their asthma. So getting those connections made. All of those are things that we're trying to do.
You're talking about Sandy Anderson from More Refreshed in Austin.
She's done an awesome job.
That's been about 4 or 5 years. Is that kind of a pilot project of your
It was, and it wasn't ours, but she sort of stands out as something that we model to try and replicate in other communities.
And Laura, in terms of the curriculum for your students, is there anything in there to sort of help them help community members be better advocates for their own health and create a culture of wellness?
Mm-hmm. Yep, so the first semester in the RN program is about the culture of wellness and how to, instead of just treating a condition, how can we have prevented that before it happened? It's all about prevention now. How can we prevent? How can we educate people to make better lifestyle changes? They do a lot of education on that, so we do really focus on that, and it's changing now where it's more preventative medicine than just treating the disease. How do we prevent it 10 years ago?
But
Like,
are there wellness jobs to be had that weren't there before? I don't, if you're a nurse?
Yeah.
So an example, we have panel managers, which is, it's not a licensed position, but they're individuals who use an application, a program that we've developed that pulls all of an individual's information on what you're due for based on services you might be due for based on your chronic conditions or your age and your gender, and pulls that together and sends a letter out to you that says, you know, you're 50, you know, you're due for a colonoscopy or, you know, mammogram, or your, you know, A1C if you're diabetic, et cetera. And so those are new positions that are now
Okay.
have come about in the last couple of years.
And that's not based on that patient's lab tests or anything. It's more using big or data and knowing about that person and saying you might take advantage of this.
So it's based on all sorts of things: their age and their gender and their lab results, and when the last lab result was, and what the result was. So if it was too high, you're going to be due for a recheck sooner than if it was within its normal range. And so it uses all that information to suggest when that patient comes in.
Do you track any of the satisfaction level, if you will, of patients in rural areas and what they think about their health care? I know you're generalizing and not just talking about our area, but shed a little light on that.
So patient satisfaction is one of the few areas where we can generalize with respect to rural healthcare, and it's being used as part of how we measure quality these days for reimbursement purposes. And the bottom line is, on average, if you ask patient satisfaction, if you have patient satisfaction questionnaires responded to, whether it's inpatient or outpatient, your results are going to look higher for rural hospitals, for rural physicians. And why is that? Well, the urban hospitals, the larger hospitals say, well, you must not be measuring things right, obviously. And the answer is, people who provide health care out in rural areas are not surprised at all, because if you're in the hospital and the nurse is your neighbor, when you see your physician in the supermarket, you've built a relationship up that even if I get terrific care up in the Twin Cities, I don't have that kind of relationship with the health professionals in the community. And so it really does engender a feeling of we're in this together, we're one big family. And so what we've seen historically is the information system is called HCAHPS, and it's trying to get consumer assessment of the health care they received. And it's, on average, it's higher in rural areas. And it's one of the few areas where we know it's going to be on, and yet there are a decent number of rural facilities that won't. It takes some resources to collect that information, and they won't do it, even though it's clear. It's pretty clear from most that the results are going to be good.
But are those places where the old method's going on, that if there's something wrong, I'm talking to the doctor, and I want to talk to the doctor now, and I'm going in there?
I think there's two sides to every issue, and we're talking about, if we're going to go to population health, changing provider behavior, but we have to also change consumer behavior. We're talking about different ethnic groups, and whether it's their thoughts about adherence to medication or vaccinations is another good issue with respect to how different groups view vaccinations. Some things that are viewed without doubt and questioned by some groups in the population. Other groups don't think the same way, so it's really challenging.
Do any of you have any experience in terms of community needs assessments and conducting those, and how helpful those are in helping us figure out what to do in rural communities regarding healthcare?
I had to do, for one of my courses, I had to do a community assessment. And that was, actually, I thought that was the best course that I ever took, because it made me realize what determines the health of a community and how do you find out what the issues and problems are. And so we focused on a community in upstate New York, and what we found was there was a high level of asthma in this community. And it was based on, they had a river that went through the town, And like every year it would flood, and houses got flooded, and so there was a lot of mold in a lot of these homes and also in the school. And they just had a huge epidemic of asthma in children there. And so that was kind of fun to research that and find out what the problems were and then how to address those issues. And so in this community, they did not have access to health care, very good access at all. And so that was one of the problems that we had found in this community.
So if somebody's watching, oh, go ahead, Dr. Bunkers, I saw you were trying to get in.
So the hospitals are responsible in conjunction with public health who are doing the community health needs assessment, and we've done several for the rural hospitals, and there is sort of an underlying theme. Obesity is a huge problem. We know it leads to a lot of chronic illnesses, diabetes and other illnesses, heart disease. Behavioral health is another sort of a common thread, especially in Minnesota, in the Midwest, that we don't have enough access to behavioral health care. And depression, anxiety, things like that are a common cause of medical problems.
And that service is growing in Albert Lea. That's where some behavioral health facilities are expanding.
Right.
If a community leader is watching this, I mean, can they interact with the clinic, for example, in your program to try to figure out how do we make our community, our county healthier? Or is that not the way it works?
We would love to. So any community leader that's watching and wants to reach out, we would love to work with them.
So what I'm sure I'm missing the issues. What are there barriers to making that happen, or?
Well, who are the individuals and who pays for what? I think it sort of always comes down to.
Do you work with county health departments on this, or not too much, or?
We're starting to.
And there was a state of Minnesota, the ACEs. Now the ACEs survey, where they ask communities about lifestyle and so on, and from that develop sort of a prediction model for young people about future health concerns. And I think that was directed by the state, the Department of Health. I don't know if that's something, do you work with them on funding your projects, the state more, or?
Not so much.
Not so
We
much.
have a grant from Center for Medicare and Medicaid Innovation Center that was developed to change the model of healthcare toward one that's more focused on prevention and chronic condition management. So that's a federal government program grant that we received.
But I think it's important to point out that needs assessment is a local issue. And whether it's at the state or the local public health department, the challenge is the local public health departments don't have a lot of financial resources to do those kinds of surveys. So we have a commissioner of health, Ed Ellinger, in the state who felt it was important, and they've done over time longitudinal surveys trying to understand what the baseline status was and how are things changing in terms of people's responses to that.
Okay.
The key is, so what happens with that data, and do local communities then use that data in conjunction with health systems or in conjunction with their own local providers? And I think that's the thing. Can we use that data to change things?
I wonder also, as we're wrapping up here, last couple of minutes, just, you talked about reimbursement, the costs. We sent a graph out, a little chart of insurance premiums and costs going this way on the graph. We'll show it on the screen, while people's salaries since 2000 have been going up but really small, and that gap in the amount of my paycheck that goes to paying for it is just going up, up, up. Is that something that's got to be fixed, especially for rural folks like farmers?
We all face that. I'm lucky enough to have insurance through my employer, but over the last 5 years, certainly, that employer has put more and more of the risk, i.e. the payment for healthcare expenditures through out-of-pocket costs, deductibles, co-pays, et cetera, on me. And that's happening all around the country with large employers, small employers.
So are we just
and
learning
farmers.
that this is more of the real cost? Folks, you had it too good for too long, and now this is really what things cost?
Well, our health healthcare expenditures in this country are dramatically increasing. It's slowed down a little bit actually over the last few years in terms of the rate of growth, but it's still increasing dramatically. If we want all these new technologies, et cetera, and specialties services, we need to find a way to pay for them. If we do population health and we can start getting people to take care of themselves a bit more than they have, hopefully that would reduce expenditures because people wouldn't be using the system as much. It's important to there are a couple things important to understand, one of which is that 1% of the population basically has 20% of the healthcare expenditures in the country. 5% have 50%. 20% have 80%. So there's a small group of very high risk, high cost individuals in our healthcare system. And what we haven't been able to do is to figure out how can we make those expenditures low. And that's a really challenging problem that people haven't been able to solve, but that's one way to look at it. The other, what's also clear is it's not the inpatient hospital side that's sort of doing this. We all know about issues related to access to to drugs. And though it's about 22% now of all our expenditures are in that arena, yet it continues to grow, and it's one of the largest growing. The outpatient side that we talked about is really the largest part, whether it's the outpatient hospital side or the ambulatory care side, and that's about half of the pie. And so those are the areas that we need to focus on. And you know, we have battling sides politically about what to do, but I think they both sides at this point agree we need to do something about the drug expenditure issue. And so hopefully, no matter what happens, that we start trying to address that issue.
I know that there's some studies too that people who have insurance and have good insurance might overuse their health care or go too often, further making issues with the cost structure. It's not just people going to emergency rooms that don't have coverage, it's people with coverage using a lot of health care when maybe they don't need it. I don't know. Dr. Bunkers, do you run into a lot of, you probably get good screening before you see a patient they've gone through before they get to you, that they need your help.
I think we do see people accessing emergency services that potentially don't need to access the care that's delivered by staffing in an emergency room. It's a very expensive setting. And so if you go into the emergency room because you have a cold, that's the extreme example, you're overutilizing healthcare dollars that could be better spent in other places. Or if you bump your finger or you hit your head and you think that you need an MRI when maybe you don't need an MRI, that's a very expensive procedure. I think we've come to expect sort of the Cadillac care in America, partly because we were shielded from the costs with insurance paying for the costs for so many years. Well, it's for a number of reasons that we've talked about. It's become very expensive, and so now those costs are shifting to us, and I think we're starting to see that it plays out in the market a little bit more if you're responsible for the things that you're asking to be covered. The hard part is that you don't always know what, as a patient, what's important and what's not important. And I think that partnership of trying to help train our medical professionals, it's a partnership in deciding what care you need. It's not for the doctor to decide for you, it's for you to decide together what makes the most sense for you, and hopefully that can help bring down costs.
And have you seen any models in terms of that kind of patient partnership education where patients can kind of figure out, what is it that I need, what is it that I don't need?
Sure, we have shared decision aids, so I'm trying to develop more and more of these, so pictorial representation of here are all the kinds of medications that are available to you as a diabetic person. What's most important to you? Is it cost? Is it frequency of dosing? Is it side effects? And so you can play all that out on a card, and then you can together make a decision instead of the physician just saying, here, take this medication, not knowing that you can't afford that medication or that you don't want to take one because of your lifestyle that's, you have to take 4 times a day.
Dr. Moskowitz, will we see robots coming out to farms in 10, 20 years doing checkups on the folks out on the farm and not really speaking to a real person?
I doubt that. I think we're going to see, if we see robots, they'll be more likely be in surgical suites, in the hospitals, et cetera. But what I think we will see is much more telehealth, telecommunications that are going to link distant centers with primary care clinicians who are taking care of farmers. I think that's much more likely.
That's on the horizon, maybe, Dr. Bunkers? All right.
Hello.
Go ahead.
Laura, do you have any, I guess, words for any students out there that are considering nursing or other health professions about the future?
Well, I always tell all my students, if you go into nursing, you will never see an unemployment check. There are so many possibilities out there in nursing. Like it's exploding right now. What all the different areas you can go into, and you know, they'll always find their love depending on what they do. When they're in nursing long enough, they'll find their passion, and that's really fun to see that. But there's just so much. There's so many possibilities out there. It's
Okay,
endless.
we'll leave it on an upbeat note there.
Yeah, sure. We'd like to thank our guests for the time they've given us to share their expertise.
This is a large, obviously complex topic, and we have barely touched the surface, but we hope you've learned maybe a bit about the future of rural health care in our region.
You can find this program on the KSMQ YouTube channel and on our website, ksmq.org. For Eric Alston, I'm Nicole Fenoy-Amhar. Thank you for joining us.